Ladies and gentlemen, my second lecture for today is about the stemmed or pedestal cup. Difficulties in revision acetabular arthroplasty are to reach a good primer stability, to have a good and adequate contact with the host bone, and of course to reconstruct the hip center. And these reconstruction options depend very much on the bone quality, on the bone stock. And we all know this Paprosky classification of the acetabular defects, and we talk about this 3A and 3B defects when we mean large acetabular defects. What we have for options to reconstruct or to treat such defects? We have cages and reinforcement rings. We have the modular reconstruction systems, the TMT system. We have cup cage constructs and also custom-made prostheses. We can combine this with structural allografts. We can do a cemented cup revision with an impaction bone grafting, already mentioned. And we have this pedestal or stemmed cup. When I look for my own cases last year, with the question which systems I used, and I see that the pedestal cup was used only in 3 cases. That means it was used very rarely. Nevertheless, there are some indications. The pedestal cup, the principle is a cementless anchorage of the shaft in the preserved dorsal ilium. The pedestal cup consists of an hemispherical acetabular cup with a 70 to 90 millimeter long conical ribbed shaft and 2 additional reinforcement rings, as you can see here. Implantation is in 10 to 50 degree inclination of the stem and 10 degree from anterior to posterior direction. The pedestal cup gives us a good primary stability by encouraging in a preserved dorsal ilium, and you can varying the length of the implant. That means restoration of the center of rotation. You can equalize the limb length, and you reach an optimization of the abductor strength. And this is a case with a severe acetabular defect, Paprosky 3A defect, and this was after 18 years of primary cemented total hip arthroplasty, and here in this case we changed it to a pedestal cup. And another one is an also 86-year-old lady with a surgery revision within 2 months comes to our department, and here we also use this pedestal cup. When we looked to our own data, we treated 50 cases or looked for 50 cases which were treated between 1996 and 2001. So we did 43 for aseptic loosening and 7 for a girdlestone hip situation after septic periprosthetic joint infection. The mean age of these patients were 70 and the mean follow-up were 38 months, and our operation time was for just revise the cup, 97 minutes in average, and for complete revision of the cup end stem, it was 143 minutes, which is comparable to all the other revisions. Blood loss also not different to any other revisions with other systems. This is the clinical outcome here, the Mulder-Aubigné score. So you can see this in typical scores. Did you get in a revision cases, and brackets you see this compared to patients with a reconstruction ring. So no difference, and here the Harris hip score were also quite common for patients after a revision of the acetabulum. Looking for our complications. We have some intraoperative complication. This was a temporal sciatic nerve palsy and a dislocated K-wire. The K-wires are necessary because this is where the drilling is performed along these K-wires. And our early complication consists of 8 dislocation, which is very high, 16% dislocation rate, with some wound healing problems, and we have some alterations of the sacroiliacal joint in 3 cases. Revisions was in the early period necessary caused by luxation, changing the liner, and to do an open reduction. All luxations were in dorsal luxation. And late complication were 2 periprosthetic joint infections and 6 aseptic failures. This was caused by migration and definitive loosening. And looking for looking for the failure, what was the reason, or what was could we see in implants? They didn't, or they were loose and migrated. Then one thing was the lateralization of the center of rotation. It means it was an inadequate surgical technique. You can see the abduction angle is too high, and that means a lateralization of the hip center, and this was accompanied with a loosening, as you can see here. And we looked for the, we compared here no cranial migration and cranial migration, and looked for the lateralization, and can show the significant relation to lateralization of the center. Another problem is if you have extensive defect of the cranial wall, so that you have no lateral support, as you can see here. Also this problem, if you have no good bone quality in the lateral side, also we lose this additional bone graft, then you have also a problem that the cup gets loose. What you need is, with a pedestal cup, and good bone stock and good contact here in this pedestal area. This enables you a stable, stable fixation of this cup, and reduce the risk of loosening. Another problem is if you have multiple penetrations by screw holes, as you can see here. Is a patient with a loosed reconstruction cage, and this is necessary. There's still lots of screws here, and caused by the screws, the ilium is multiple perforated, and after such situation, you implant such a pedestal cup, then you have this problem. There is no good quality of the bone, and the consequence is loosening of the cup. And what is a real prerequisite to have a good anchorage of this cup is a sclerosis of the acetabular, cranial acetabular wall. If you have this or if this is not the case, then you get a problem with a good fixation. As you can see here, this area beside the lateral bone support, you need here a good sclerosis. So the fixation of the cup is accompanied with this. Good. Looking for the risks. So in conclusion, lateralization of the center of rotation, multiple penetration by screw holes, weak or devitalized bone without sclerosis means no lateral bone support, an inadequate bone interilium, and maybe also risks are the sacroiliac joint encouragement. As you can see here, this is a patient, the cup was too perforated the sacroiliac joint, but this was not a cause for loosening. You can see 5 years, the patient is already walking, but it's not how it should be. Main early complication in 60% luxation rate. So this is a problem of the implant, because the angle of inclination and anteversion is predetermined by the positioning of this of the pedestal cup, and in turn by the pelvis. So I have no good options to have an impact or influence the inclination and anteversion, because, as I mentioned, this is predetermined by the pelvis and by the ilium. So, unfortunately, this 50 millimeter diameter cup, there only you can use 32 millimeter liner. 36 would be better, but it's not available. Also, then would be the liner very thin. From our point of view, the indications to use a stent or pedestal cup is if you have a large bone defect, with such a steep slope. You can see here, if you see like the Eiger Nordwand, then you can think about, in connection with a deficient dorsal acetabular rim, to use such a pedestal cup. And the prerequisite for using is, as I mentioned, adequate lateral bone stop, a sclerotic bone at the cranial acetabulum, and a good bone stock of the ilium. Thank you very much.